Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric Kelly. Today I am with Tim Cranton, a faculty member for the college for many years. He teaches on our Year 1 bachelor's degree program as well as tons of other things. And Tim, it is a pleasure to chat with you.
Good morning, Aebhric. How are you guys this morning?
Is good, and I'm here to learn about offshore work for a medic. And you have been doing this for how many decades now have you been doing offshore medic?
Now you're going to make me feel old. Goodness me, I was talking to somebody about it this morning, actually. So it will be over 25 years now that I've actually been working offshore. So nearly 30 years.
And you just got a new post in a brand new FPSO. We'll talk about that, but you basically have posh quarters and an amazing ship. I can't say boat, can I? So tell us about this new job you're on about.
Yeah, so basically I've transferred from the last of the Shell rigs, or shall I say Shell Brent rigs. So that was the Shell Brent Charlie. So that was a fixed installation. But I'm now transferring across to a floating production storage and offloading unit that is currently in Haugesund in Norway, having the final completions done for her build. So I've actually just joined the project. I'm currently sitting in the project office, tasked with bringing online the medical facility, as well as implementing various procedures, etc., which is what I'm writing right at this moment in time, actually. So I'm writing a medical emergency response plan. So these kind of jobs don't come about very often. To actually be on a brand new build that's never produced before is something that only comes about in a blue moon. And it's pretty exciting. I've only ever really done this once, and that was on another purpose-built FPSO. And pretty excited. I actually got on board yesterday for the first time, and seeing things with the plastic still on is a little bit strange. But it's pretty cool. I'm in the yard, and I saw the sick bay also for the first time yesterday, and I'm pretty impressed with the layout. So tell us about the sick bay, or tell us about your quarters, or what's it like being on this ship? So it's a round installation, so it's not actually ship shaped. That's easier said. It's not actually ship shaped. It's actually round, but it floats, and it will be anchored to the seabed. And then the pipelines or the hoses from the subsea template will tie into the bottom of it. But it is 6 stories high. It starts with its tanks, so that's kind of in the base of the unit. That will include the oil storage tanks as well as the ballasting tanks. Then it's got a marine deck, so that gives you access to all of those tanks as well as some equipment. Next level then is the process deck, so all the production facilities and modules are parked there. And then from there upwards, essentially we have our control deck, we have accommodation deck, so there's 2 levels of accommodation deck. Well, there's actually 4, but they're integrated with office spaces as well. We have a very large dining area, kitchen, as well as kind of recreational facilities. That includes a gymnasium and a sauna. Nice. Like I said, we've got several levels of accommodation. On my level for the sick bay, that's level 5. That's on the 5th level. And that includes the medical suite. So I've got a clinic itself. Next door to that, I've got a wet room, bathroom, kind of sluice room. Next door to that, I've got a 1-bedroom ward. And then next door to that, I've got the medic's cabin, which I will have to myself as well. Currently, everything is empty. like I said, there's still plastic on the walls. And when I went there yesterday, there were some guys actually doing some painting and grouting. But the medical bay is situated right next door to the heli deck, heli admin lounge, which gives me direct access to the heli deck to be able to evacuate a patient. So it's a pretty big installation. Like I said, capable of storing 450,000 barrels of oil with a daily production rate of 45,000 barrels of oil. So it's pretty big. Houses or will house maximum of 80 POB, if I get the numbers right.
Yeah, so I pulled this up on Google to just see the images. It looks like a little castle, and then I zoom in, and it's not little at all. And there's a picture here with a normal size offshore huge ship. Tiny castle is not tiny at all.
Yeah, it kind of doesn't do it justice until you're actually stood right next to it and this structure is kind of towering above you. And you have to remember as well that a percentage of that is actually going to be below the waterline. So yeah, like I said, it's a big structure. Walking around it, being able to walk all the way around the deck levels yesterday was again pretty interesting. One of the things I actually like about FPSOs is in terms of the production and equipment side of things. On an oil rig, traditionally, everything is stacked on top of itself. So you always have these various layers of modules. But with an FPSO, essentially, I've got a marine deck and a process deck. So in terms of access to the plant itself, it's pretty straightforward. I'm not having to kind of go up various levels to find certain modules to be able to access certain areas. So in terms of patient response or response out on the plant to an incident, it's for me personally, I think it's more straightforward. The difficult part of any kind of medical response on an installation like this would be into its tanks. So we're required to go inside the oil tanks for inspection or the water tanks for inspection, the ballast tanks. So access egress from those areas is pretty tricky. And in fact, we've currently got with us an inspector or rescue specialist from the Mines Rescue Group, which is an organisation in the UK that specialises in confined space rescue. So I've spent some time with him, and we were on the installation yesterday, looking at various challenges that could occur when it comes to patient access and rescue. So yeah, a lot to think about at the moment.
So do you need specific training for this, or just anyone with an offshore medic cert can walk onto this job?
I think there's kind of an impression that you can do your survival training, do your offshore medic training, and then just walk into this. But I literally spent, even now, I mean, I've done a whole host of courses before I got here. But certainly when I arrived, it took me 2 days just to complete the on-site safety training. So there's a lot of additional things. For myself, I have my offshore medic certificate. I have my offshore survival and firefighting that is up to date, and I've just renewed my offshore medic's ticket. But I also have additional training in things like rope access, confined space rescue. We have to do specific training on escape from tanks or vessel spaces, and using an enhanced level of personal protective or respiratory protection equipment in case there's an O2 depleted atmosphere and a personal alarm goes off. If we were in one of those spaces, so there's a fair amount of additional safety related training that you have to go through. That's usually provided by the organization that you're working with. But again, having qualifications like radiation protection supervisor and other occupational safety and health topics, for instance, medical screening, being able to do things like face fit testing, to be able to provide emergency equipment to other crew members who may need to help you or need it as part of their day-to-day jobs, providing that service. So that's additional training that you might require. But as I said, most of the time, the organization you work with should put you through that training, or when you arrive on site, I would expect that you would need several days in-house training to bring you up to speed with the relevant procedures and the like. So there's a lot of additional stuff, I think, other than just the medic's ticket.
So this seems to be a pretty posh option compared to some of the smaller boats. Is this your 25 years of experience? Did that help you get this job over someone who's a brand new graduate?
Arguably, that's a good point. I would say yes. I mean, experience counts. I've been talking to one of the project managers this morning who's kind of been asking about my background because obviously I'm new here. And I've had a career break over time. So I've started out life as a medic and just done those kind of medical specific tasks, and then had a career break. And I actually went into health, safety and environmental for a while as a safety advisor. So I did radiation protection. I did my NEBOSH, so the National Education Board for Occupational Safety and Health in the UK. I did various qualifications with them. And that all helps. Having those extra tickets, or what we call bolt-ons, make a big difference when it comes to potential candidates for jobs like this. Certainly for myself, there's the two of us here. There's actually three medics that will cover this particular installation. That way we have continuity. So if someone goes sick, someone else is available to step in. But myself and one of my colleagues out of the whole medic team that work with United Health Global that are on contract to Shell, we have, between us, we must have at least 20 or 30 years experience on an FPSO. So again, one of the things for our selection, was our experience, and we were actually asked, or most certainly myself, were asked specific questions on the type of installation that we were going to be going on to, and and what we would need to do and what challenges we might come up against. So most certainly experience was necessary on my CV for this job. And they asked me during the interview process, which we had to all go through as well. There were quite a few applicants for this particular job, and as I say, thankfully I was one of the final three that secured a place.
So for the new graduates that would want something like this, what are some tips that you have? So they have their paramedic or nurse or CMT, they have their offshore medics, their bolt-on courses. How can they stack their CV in a way that's going to get them these jobs?
So the best thing is, as soon as you qualify, you've got your paramedic certificate, you've been able to find an organization that will train you as an offshore medic. Some of those organizations, a lot of it is also about networking as well. Some of those organizations will possibly offer you a position with an agency that they are part of. One of those organizations is Icarus, a very large a multinational company that provide offshore medic training, but also have an agency for medics and currently provide life support services to various oil and gas companies and the like. So certainly doing a course with one of those places could possibly open up things for you thereafter with them. But the main thing is, as soon as you qualify, is copying your CV, 100, 200 plus times, sending it to every company in the phone book. And even if it's just a couple of days cover that you're offered, a week, 2 weeks, maybe a couple of trips, do them. Build up your resume that way and get as many jobs, short term, long term, as you can, and you kind of stack up your CV that way. That's how I started. I remember that I did my offshore medics ticket, and because it was the better option than going into commercial diving, I had a choice, and I figured that this was the being a medic was the safer option, and I literally got myself a train ticket. I lived in Peterborough in Cambridgeshire at the time. Got myself a train ticket, booked myself into a B&B, and I went up to Aberdeen in Scotland, and I had copies of my CV in my hand, and I went to pretty much every oil and gas company I could find in the phone book. Put my CV on someone's desk. I spent the best part 2 or 3 days doing this. I actually managed to get a couple of interviews as well because people were looking for, ad hoc cover. And within the week after I got home, I was actually offered a couple of interviews, and by the end of 2 weeks, I had a job secured. But you've got to be pretty motivated. Jobs will not come to you. You're going to have to go to those jobs. And like I said, if that involves actually going to somewhere, putting your feet in someone's in tray, that's what you've got to do. But if it gets you that first job, that's that old saying, getting your foot in the door. Getting the first job is always the hard part. Once you've done that, you should be able to move forwards from there.
So our first year BSc students, after they complete year one with yourself, they can register as paramedic and they can take the HSE Offshore Medics course and they can get the job. But would the ones who finish all 3 years and have a bachelor's degree, would that weigh heavily on getting a job?
Absolutely. I mean, we are most definitely now looking at enhancing the role, enhancing its recognition. In fact, like I said, I'm doing this MER today, and we don't call ourselves medics anymore. We're healthcare professionals. And I think if you were able to come into this job, especially with our BSc, that's definitely going to put you in much better standing than arguably coming from an unqualified background. And that's one of the difficult things for a lot of people that would be suited for this role, especially kind of ex-military guys. Unfortunately, they're coming out of the military, but they don't have a civilian version of the job they've probably been doing for a long time. So enabled to quantify all of that experience, actually having something like our BSc is going to put them in much better standing for that job. And again, our BSc is quite diverse. So it's not necessarily about finding that oil and gas job on a rig. It could be a remote mine site. It could be working for National Geographic or the History Channel, doing a movie. It could be working on tall ships that are doing sailing around the world. I know we've got some of our graduates have done those things. So it opens up a lot of other things other than just working. The possibility of working offshore. There are other options too, and tropical medicine. If you're going to be going to Papua New Guinea. Again, I know one of our graduates, or one of our current students, I think, has managed to do things like that, going to Africa as well. So having that experience, I think also that a 3-year program gives you, because we do clinical placements as well, and having that on a resume, and that's already experience of working at a remote or certainly resource poor location. That's valid. That's experience too. If you've just come from a university classroom, or kind of like one of these short course classrooms, it doesn't give you the practical experience, and that's what most employers are looking for. They want the post qualification clinical experience, so that they know they're not just getting somebody who's maybe got the head knowledge, but also somebody who's got the practical skills and experience. And I think that's really important to gain as well.
So you have the job. So what are your roles? What are you expected to do on this little castle in the middle of the ocean?
So, I mean, right at this moment in time, I'm not providing any kind of medical service. I'm not, having to do a sick call. I'm not providing any emergency response role. I'm literally in a projects office, and I'm reviewing various documents. Like I said, the medical emergency response plan, Yesterday, I was also looking at confined space rescue as well. I'm also looking at medical equipment. So now I've got a sick bay and I've seen it. Now we need to think about what we're going to put in it. We've got several months yet until we're due to sail. So I'm reviewing inventories at the moment, and I've already got some items that are on pre-order. So again, I've got to go through and check all of those and make sure that's compliant with our company inventory for a static location. So that's the job I'm doing kind of right now in the yard. When the equipment arrives, which will be shortly before it sails, our job will be to place everything in the cupboards and the cabinets. The emergency response equipment will need to go in its various places. And then we will need to initiate an inspection program to make sure that it stays fit for purpose and it stays serviced as well. Once we arrive offshore, then I will be providing on a day-to-day basis emergency medical response, as well as the general medical duties. So having a sick call, anyone with any kind of ailment obviously can come in and see us on a daily basis. But we'll also be responsible for occupational health as well. So again, one of the things I'll be setting up here in the office is things like the inspections that we require to do. So we do noise and we do noise management, in which case we have to set up a program where we'll go to various areas of the plant and make sure that they conform to the necessary standards. So noise. We also look after COSH. So COSH is controlled as substances hazardous to health. So essentially any chemical that arrives on board the installation, our role is to ensure that it's used safely and that all necessary measures are adhered to when it comes to the use of those things. We also have things like baths. So now, when I say bath, I don't mean the soap and water type that you would have in your house. I'm talking about the chemical baths that might be kept in workshops for cleaning tools or cleaning equipment of hydrocarbons and hydrocarbon residues. What you can get in those baths, because the content of the chemical is not always changed all the time, is actually bacterial growth. So we'll be monitoring the bacterial growth of certain facilities that are used to wash and clean equipment. But talking of bacterial growth, one of the main things we look after is potable water. So we have to make sure that our pot water systems, again, comply to a certain standard, and we will routinely collect samples, so water samples from various areas of the installation, including outside on the plant, because we have to, consider things like emergency showers that are used in case somebody gets a chemical spill, something in their eyes. We have to check and make sure that there's no bacterial growth. So that's, your usual kind of coliforms, but also Legionella as well. So Legionella management, that's part of our role. And then on top of that, we'll also have our equipment. Like I said, we need to make sure that that's inventoried, that doesn't go out of date, and it's inspected and tested. And that's also fixed safety equipment. I already mentioned eye wash stations. So we have safety showers. And again, the expectation is on a routine, we will go out and we will flush the system, turn on the taps and make the deck wet to make sure that if somebody did need to use it, they're not getting, dirty brown water or rusty water come out. And we'll also look after things like eye wash stations. So emergency eye wash, the bottled eye wash, we'll make sure that they're secure. There will be first aid boxes out in the plant. Certainly in some of the plant rooms or the workshops that may be out there, we'll make sure that they're checked on a regular basis. And we also place defibrillators too. Not only do we have a defibrillator in the sick bay, but certainly for facilities like this, we may have 2 or 3 of those that will be in certain other locations, like the mess room. They may be in an emergency switch room or a large electrical switchgear room, and then another area of the plant as well. So there's a lot of equipment for us to look after on a daily, weekly, monthly basis, as well as our occupational health role, which is also dictated to us by Shell's occupational health department, which we liaise with on a daily basis. So it's not just about seeing people on a daily basis for coughs and colds, the odd person with a splinter or something in their eye, or maybe something worse. There's an awful lot of other things to keep us busy on a daily basis.
So about equipment, what type of ALS level equipment do you have?
I was actually looking at that this morning, and I asked yesterday when I was in conversation with somebody if we were getting LifePak 15s, but then in the medical order this morning, I noticed there's LifePak 12s, but they've got ETCO2 capability that I can take a BP with them. I've got SpO2. It's a manual defibrillator, so again we can do cardioversion. We can provide a high level of ALS. Airway management is all there, all the way up to the top of our airway ladder. So if we had to do a surgical, we could. But yeah, our ALS capability is actually pretty good. As you know, the difficult part of ALS is if you had to provide resuscitation is going to be ROSC and then maintaining a stable patient over a prolonged period until such time as evacuation can occur. And that's the challenge. So we've got all the necessary drugs. We'll have pressors. We'll have the usual cardiac drugs. And again, just this last month, October, I did my ALS refresher at Nottingham University Hospital. So I'm relatively up to date with it. And as I said, we have full ALS capability with the ability to be able to maintain, as I said, a post-resus patient until such time as we can get someone off. We don't have the ability to do any cooling, but that's an interesting thing to possibly explore and discuss with somebody, because I know that's certainly something we discussed, the induced hypothermia, but something to discuss with our top sides, I think, once we get all our facilities in place.
So what ultrasound device do you have?
Do you know what? I knew you were going to say that. I actually don't at this moment in time, and it's on my list already this morning. I've actually written it on my notes. Ultrasound and having an IQ butterfly or something similar, I think most definitely could enhance our ALS capability.
Do you think they would supply you with that, or you'd have to buy it yourself?
They seem pretty open, actually, at the moment. Yesterday, I put a request in about personal protective equipment, and PPE is certainly in the oil and gas industry. It tends to be a very bog standard level of personal protective equipment, as in a flame-proof coverall, a V-Guard kind of peaked hard hat, safety glasses, gloves, and a pair of boots. And that's pretty much what you're given. But that doesn't really satisfy, an emergency responder. Our fire team, emergency response team, they get fully kitted out, fire helmets, turnout gear, boots, etc. But the medic is kind of expected to go out the door with pretty much the same PPE that everybody else wears on a daily basis. And I've questioned that, because I know what it's like to have to kneel on the ground for a considerable period of time with no knee pads, and I'd rather not do that, certainly not at my age anyway. I've put that in. I've said, we need some kind of coverall that actually is fit for purpose for emergency response. The same with having, headgear, having some kind of, rescue helmet, but high vis as well, something that actually demonstrates who we are, so that people can, identify us, quickly and effectively. But they've been pretty receptive of that, which kind of surprised me, because normally it's go and see the storeman and they'll give you some. But they've said, no, we'll sort you out with that. I think, for us as well, new installation, they want to, show a good picture of us, and the higher our kind of level of professionalism, the way we look obviously counts. But I think they could be receptive. I just need to convince the right people. But the other thing as well is, and we have to consider, whilst it's fine for myself, having completed the ultrasound course at Addenbrooke's, like yourself, I kind of have those enhanced role or the bolt-ons, but not all of us do. So having a level of training that all of the medics are required to have, it can be not the same for everybody. And most certainly, having just done the Offshore Medic refresher, disappointingly, ultrasound is not even discussed when we know that it's an excellent diagnostic tool and can give us an awful lot of information.
If they're spending $1 billion on making this round fortress, another 2,500 for ultrasound might not be that huge of a cost.
Exactly. I don't see it as being a big cost. Like I said, unfortunately, I'm going to have to convince the right people. Maybe if I can get one of my own, and then, or maybe borrow one from the college, and then do a bit of sale and convince them that this is what you need to do.
So that would definitely be a good option. And there's tons of research on austere use of ultrasound. And I've talked from the top down as well with some of my colleagues in the Royal College of Surgeons at Edinburgh, and they know that the need for it and the use for it, but they're worried about keeping medics proficient, and that's justified.
I mean, and there's keeping medics proficient. Like I said, it's not the same, throughout the board. I mean, I don't profess to be the most highly trained medic in the world. I know I'm not. And I'm absolutely sure there's other guys out there with a lot of experience kind of over me medically and clinically. I've been arguably lucky in that I've been in a position to be able to get, that experience and the enhanced level of training. But like I said, unfortunately, that can't be the same for everybody. And a lot of the time, again, it's about opportunity. But if we could, certainly, I think it should be made part of offshore medic training as a standard. But again, other institutions maybe think differently. And cost is also what it comes down to at the end of the day. But again, like you said, if they're spending, billions, and I know they pretty much have on this project, what's an extra 2,500?
What's interesting is there are tons of offshore installations with X-rays. Do you not have an X-ray in yours?
I do not. No, I don't. Do you know? I don't think I've ever met one. There was a floating, a semi-submersible that had a hospital on board. I think it was a Poly Concorde, and I think they had something like that. You might get that on one of the Norwegian sites. I can't say I've actually seen one in, in a UK one. But again, it's a little bit like the bone saw. Medics doing field amputations, I don't think is ever really going to happen. But there's always a bone saw on the inventory. So you never know, there may be an X-ray.
Never know. So you're on this round castle. Where is it going to finally be? Is it in the North Sea, or are you going somewhere else?
So no, it's going to be the UK North Sea. It's going to be in the Shetland Islands. And in fact, if I bring up my medical emergency response plan, which I've been working on, I can pretty much tell you where it's going to be. It is going to be approximately 160 kilometers from the Shetland Islands, in a water depth of 165 meters. I've got located 150 miles. 241.3 kilometres to the northeast of the Shetland Islands in the UK North Sea in 165 metres. So that's 541 feet of water. So a pretty isolated location. By helicopter from Aberdeen, it will take us a good 3 hours plus. So most likely we would fly fixed wing to Sunborough in the Shetlands. That's about an hour's flight. And then we'll take the helicopter to the Penguins, so that's probably going to be another 2 hours.
And I'm looking at that on Google Maps. You're up there, equal to Iceland. I mean, that's way north.
We are, and again, if we a sharp turn right, and we're in Norway, so yeah, we are going to be one of the most northerly assets in the UK North Sea.
So I don't have to worry about slim screen that far north.
Do you know, it's funny you say that as well, because looking on the inventory this morning, I noticed that they put sunblock in it. So I can't say we're going to be using much of it. It's going to be there for a long time without use.
Indeed. So you're in place now. That's your rotation in the near future. Tell us about an emergency event, a medical event. How do you assess, how do you manage the patients, and do you bring them back to your clinic, or do you manage there, or how does a medical emergency work on your platform?
So again, if I kind of refer back to my emergency plan, that's one of the things I'm writing about this moment in time. So we actually have what we call a tiered level of response. So tier one would be somebody who's come across an incident, let's say out on the plant. So that would be our first responder, or should I say tier zero, sorry. So tier zero is the immediate response. So a person finds the casualty, so an injured or ill person. They'll only approach, obviously, if it's safe. If they can, they'll make the area safe. But primarily their role is alerting to the incident and activating some kind of alarm. So they would get help by shouting a manual alarm, call points, or one of those smash glass push button. We have telephones as well. Everybody kind of carries radios. So they would call that into the control room. So we have a central control room. And then the control room operator would decide whether to initiate a full platform general alarm, or they may tannoy and state that there is a medical emergency and request a designated first aider, which would be our second level of response, so tier one, which would be in less than 4 minutes. So we have immediate, then in less than 4 minutes, a designated first aider is expected to mobilize to the location with a grab bag and a defibrillator. That would be a standard for every response. And if necessary, they may then bring the patient to the medic who would be on standby in the sick bay, or they would determine whether a level 2 response or a tier 2 response is required, and that would be the medic themselves. So in less than 10 minutes, there would be a tier 2 response, and that may mean that for the likes of myself, I may be required to go to the incident scene, assess the patient, or have the patient handed over to me by the first responder, and then continue the medical care and evacuation from there. Most likely, after stabilization on scene, we would utilize our emergency response team. So that's our kind of fire and rescue team that we have on board. They would assist moving the patient from the incident scene to the sick bay, where further stabilization would continue. So by that stage, we'll have done our ruck truck. So ruck being the medic responding with a rucksack. The truck is going to be our emergency team by stretcher moving the patient to the sick bay, and then we're going to be in house phase until such time that we're able to move the patient. And really, that's going to be dependent upon the weather and access to us by the Coast Guard and a helicopter. And as I say, we would then hold the person in the sick bay for however long is needed, and provide them with the level of care that is needed to be able to stabilize them, and then provide them with prolonged care until such time as we can get them plain and to definitive care. So that's kind of how we would respond. Tier 3 is where we would have a multiple casualty type incident, in which case that would be something the medic would initiate, would be a multiple casualty incident. And then at all times, we're feeding information back to our control room and or the installation manager. And ultimately, it's the installation manager that will initiate response by the Coast Guard. But also, we have our topside medical provider. So again, when I get into the sick bay with my patient, I would actually make contact with the virtual health service that we have. So that we commonly refer to them as topside. I'll talk to the duty doctor. He will then in turn contact the Coast Guard, and between the Coast Guard and the installation manager, they'll authorize search and rescue to come and pick the patient up. It might not need that. It might be that we could have a non-urgent medevac, and we are able to send someone in, let's say on a routine crew change flight. Most days on my last installation, we were flying, so it wasn't too much of an issue. We could pretty much get someone home from Monday to Friday who was, a low-level patient, and we could get them into the care of their own GP or to Aberdeen Royal Infirmary that way. But I think this is going to be a little bit different. We're only going to have 2-3 flights a week where we're going to be. So access to the patient is going to be interesting for helicopters. And that pretty much covers a response. On a day-to-day basis, it'll be, people will knock on your door. We'll have a open clinic from 7 a.m. to 7 p.m. as the usual working hours. Obviously, we're on call, so we could go out any hours after that or receive a patient, say, from the night shift. But we'll have our general health service, the clinic-based facilities available 24 hours a day, and then deal with patients as they come in the door. But we've got all of the telephone numbers. We know who to speak to, and we practice this as well on a weekly basis. Again, one of the things I've been looking for is the major incident management plans, and we actually have a training program that covers a medical response and an occupational health or disease illness-related incident, and we have to do one of those as a minimum every 4 weeks. We usually do one per trip, which is each medic shift, which is 2 weeks. We'll have a medical drill, or we'll certainly do first aid training with our first responder team at least once every 2 weeks. So preparation and planning prevents poor performance, as they say.
Indeed. If you're going to be sitting on a casualty for that long, why isn't prolonged field care, austere emergency care taught to offshore medics?
I think it's the only thing I can think it is because most people already come from a military medic or a nursing background. There's an expectation that you already know about prolonged field care, so they don't feel the need to cover it in the Offshore Medics course. Although I most definitely do feel that it should be covered and at least practiced in some of the scenarios that they do. Unfortunately, again, Nottingham, fantastic venue, really good name when it comes to the Offshore Medic course. But we focus really on the short courses, the ALS, the PHTLS, the trauma and the advanced life support and medical illness management. But we don't really go into the long-term care, the nursing care, sheep vomit. We don't go into those things, and we really should. But I think it's not done because there's this expectation that to come on this course, you must fulfill a prerequisite. That prerequisite is registered general nurse or ex-services equivalent. I know you can now do it direct entry as a paramedic, but I think you've also got to comply with the standard in terms of having experienced in some form of nursing care. So most certainly GP-based paramedics that have that enhanced role are people that tend to move into doing the offshore medic thing. But maybe I've spoke about it actually on the last course. I put it in the feedback, but whether or not they'll pay attention to it, we comply to the basic minimum. And I think again, actually getting people on a course, bearing in mind the initial offshore medic course is 4 weeks, and then 2 weeks, or should I say 10 days for the refresher. And arguably, it's not long enough to cover, subjects like prolonged field care. And I think they put restrictions as well on it, time, being able to get people that are going to pay a lot of money, because that's what more time costs, and time off work when they could be offshore, doing their role. So getting people into training is challenging enough.
So the final question I have for you, Tim, is what is the most unwell patient you've dealt with in an offshore platform?
Unwell. Where do I start? I've had some interesting cases over the years that have been challenging, and you could argue that maybe the most unwell was not as challenging as some of the other ones. I I've had some difficult psychiatric cases to deal with, as well as trauma wise. I think one of the most challenging for me was a patient who was found collapsed on a stairwell, was unresponsive, showing signs of shock, decreased respiration rate, cardiac arrhythmia when the patient was put on the monitor. Essentially, from what I could see, the patient was having a silent MI, and but again, getting any kind of response from the patient, having to ventilate the patient and stabilize them that way. But the hard part was then extricating them from this stairwell, getting them into the sick bay, and just maintaining a patient that I was just concerned was going to go into cardiac arrest at any time. Thankfully, because of the level of response by the first responders, keeping the patient's airway open, it was a very good outcome. But we had to wait a long time to get search and rescue Coast Guard out. So literally having to bag a patient, having to keep the patient stable, constant cardiac monitoring. That was demanding. Patient's not bleeding out. It's just you have a patient that's so close to potentially going into cardiac arrest and then not going into cardiac arrest. That's the one that takes up more of your energy, more of your thought. You're trying to preempt problems that you could possibly get, and at the same time sitting and constantly assessing, reassessing, and maintaining. That's probably the most challenging, because you don't take your hands off that patient, because you can't. And when you have other things to think about, like talking to topside, talking to the Coast Guard, being able to obviously hand the patient over, communicating to the installation manager so we can organize other resources, there's a lot to think about at the same time. In the same respect, I've had a patient that was a psychiatric patient. He was literally found out by the lifeboats, convinced that he'd won the lottery, and his wife was on her way out with a helicopter to come and pick him up. And then that patient then getting violent, having to knock that patient down, having to use other people to physically restrain that patient before we were able to get him on a helicopter, actually trying to find a helicopter operator that would be willing to take the patient. And again, chemical restraint, physical restraint before we could evacuate them. That's been another challenging situation. I've had a patient that was on actually on another vessel, and he amputated the best part of his hand whilst trying to perform a routine maintenance task, failing to isolate a fan, and managed to chop his fingers and, as I said, his hand off. But not only that, we had to get him from the vessel to our fixed installation so we could fly him off. So there was onboard treatment by the first responders to stop the bleeding. We then transferred him using the fast rescue craft to one of our lifeboats that we lowered down to sea level. We then had to physically transfer him across to the lifeboat, winching him up to our deck. So I was then treating him to try and stem the bleeding of this injury, because it wasn't greatly treated on board, but then, that's because, they're not, doing these things and they're not quite sure what to do. So again, bleeding control whilst I had him inside a totally enclosed lifeboat, being winched up to deck, and then transferring the patient by stretcher up to the sick bay, where I could then actually apply good, bleeding control measures, physically inspect the wound to see if there was anything that could be done directly, and then evacuating the patient from there. Arguably, the list goes on. I think they're all challenging in some way or another. But for me, I think because of the location, it's not just about the medical aspect. It's also about all of the other things that you need to think about in terms of how we're going to get the patient to definitive care.
And that is a big challenge, regardless of where you're working in a remote and austere environment.
Yeah.
So, Tim, thanks for a crash course on starting a new job as an offshore medic.
Yeah, it's I do. I feel new. It's actually quite funny, despite the fact that I've got that however many years of experience, I actually do feel a little bit like the new boy, and it's exciting. And I think that's one of the things you can definitely look forward to when you get that first job. It is exciting. It's something new, but don't be afraid to speak to people. Go up to people, introduce yourself. Tell them who you are, and other people are there to help you. There's a lot of information you can get from other people. One of the first things I always do, introduce myself to an installation manager. So ultimately, that's the person that really you report to offshore, and establish good relationships with these people, especially because they're going to be people, ultimately, they're going to be helping you out in a time of crisis, and that could be when you've got a patient. So make sure that you make friends, establish good relationships with the right people, and enjoy it. As I say, I'm excited, brand spanking new sickbay, really looking forward to getting it stocked up and having it prepared for when we finally arrive in the North Sea, which hopefully will be the beginning of May next year.
Brilliant. Thanks, Tim. Appreciate that, and we'll chat with you again next month.
Looking forward.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.